Welcome to video 2 for chapter 16. So we had just finished talking about psychodynamic, which is just a newer version of Freud's psychoanalysis. Students are often surprised to hear that Freud wasn't super popular when he was alive. Actually, most people that then became psychologists disagreed with him. He certainly had some allies and people that he worked with and people he trained, but what I think most people are surprised to hear about is he's more famous and well known now than he was then. One of the groups of people that looked at Freud's ideas and really disagreed are the behaviorists. So remember, we talked about behaviorism in Module 7 when we talked about classical and operant conditioning. So remember, behaviorists think that we do the things we do because of feedback from our environment. It has nothing to do with free will and has nothing to do with our thoughts. And so the behaviorists looked at Freud and basically were like, we disagree. Around the same time, shortly after, cognitive psychologists also started to emerge and said, well, behaviorists, we disagree with you because we think thoughts play a role. It isn't just about our environment. It isn't just about the things that happen to us. It's also about our appraisal of those things. So remember, we've talked about cognitive appraisals before. And so essentially we have behavior therapy, cognitive therapy, and now a version that's the blend, which we call CBT, cognitive behavioral therapy. So I'm thinking you can figure this out on your own just based on other chapters we covered, but just to be really explicit. Behavior therapy is going to focus on exposure, meaning that people have to experience their environment in order to better understand why they do the things they do. And so we'll often expose people to feared things, for example. So somebody that has a phobia of dogs, if they do behavior therapy, they're going to have multiple experiences where they're exposed to dogs. And the idea is that by experiencing those situations or things and nothing bad happening, the person then learns, okay, notice the word learns, that there's nothing to fear of that object or that thing. Cognitive therapy, on the other hand, is going to focus on the thoughts, right? The appraisals. And so it's helping them identify the maladaptive thoughts that drive the symptoms. So you can do therapy that's purely behavioral. You could also do therapy that's purely cognitive. But I would say in this day and age, most people that do this type of treatment are using a blend, which is CBT. CBT is highly effective. And we'll talk about why I can say that and how I can say that towards the end of this lecture. Whereas psychodynamic is more controversial. I would say the evidence supporting the use of psychodynamic is pretty limited, and most people would say that it is not a super effective form of psychotherapy. Okay, but there are kind of some caveats to that, and I'll talk about it in a minute. Humanist, on the other hand, we talked about that very recently, is where you try to help the person achieve their full potential. So remember, we talked about this before from the sense that humanist psychologists think that other subfields of clinical psychology are too negative. All right, so think back to Freud. He talked about sex and violence a lot. A humanist psychologist is going to say, that's super negative, people are inherently good, we need to frame this differently. So a humanist psychologist is going to help people try to express themselves creatively. They're going to use unconditional positive regard, which basically means you validate and support the person no matter what. Family and couples therapy is where you focus on the relationship. So when somebody comes in for couples therapy, we're not treating the individuals, we're treating the couple, or focusing on the dynamics that are at play between those people. Same thing with family therapy. We often use this when the difficulties in the household are a consequence of the dynamics. So if one of the people in the relationship has depression, for example, and nothing else is really problematic, nothing else is really troubling the couple, then we're probably just going to treat the person with depression. But if the couple is pretty high functioning, each of them individually doesn't have any significant impairment, but it's more about maybe their communication or their trust of each other, then couples therapy is probably more appropriate. So these are just some of the major schools of psychotherapy. Each of these examples have different types within them. So these are just kind of broad umbrella terms that represent a lot of different specific approaches within them. Again, you can take abnormal psychology in our department, which then is a prereq for foundations of clinical psychology, where we get into more specifics of these treatments. You can go to graduate school and study these things for 5 years or more, right? This is a really complex aspect of clinical psychology that's been very much watered down here but generally speaking, these are the major schools of psychotherapy. So this brings me to the last topic. When we go to doctors, we generally want them to do the best thing, whatever that is. And so this brings up lots of questions of how do we make the decisions that we make for our patients? And your textbook talks about this in terms of evaluating psychotherapy, meaning how do we evaluate psychotherapies? How do we use science to determine which one is the best? And I'm using air quotes around best. Essentially, when you have a real life patient in front of you, how do you decide what to do? And even though this is focusing on psychotherapy, I would throw in any form of treatment or anything we could do to help the person. How can we determine whether a self-help book is the best? How can we decide if a medication's the best approach, whether they should try to use vitamins, light therapy, exercise? How do we make the best recommendation we can make? And so the biggest issue here we're talking about is what we call a scientist-practitioner gap, which is essentially where there is a gap between what science says what we should do and what real-life practitioners end up doing. Because what's interesting is most of the people doing the science aren't actually people doing the therapy themselves. Or even if they are the same people doing therapy, they might not be doing their science in a real-life way. Because when we try to design a research study, we're confronted with a lot of issues, right? We want it to be as real life as possible, but real life is pretty messy. So for example, most of the research on psychotherapy filters out patients that have multiple diagnoses. And that's problematic because we actually know most patients with one disorder have another disorder or multiple disorders. And so by filtering those people out, our patients are less realistic. We also know that people doing this research don't often include patients that are actively suicidal because they pose a risk. But we often treat people that are actively suicidal. So shouldn't our science reflect those people too? So essentially, there's a mismatch between the way we do our research and the way we actually end up doing therapy. So just because the science says something is the best doesn't mean it actually works that way in real life. There also are other issues in terms of how we do our science. So we always want to try to compare participants with a particular type of treatment or patients that are receiving a type of treatment to other patients, because we have to be able to compare them to something. Okay, because otherwise, maybe the people just improved because time passed, or maybe they better understood themselves with more time. And so we want to make sure we have something to compare them to. But in doing that, we introduce a lot of issues. Because if you're comparing a group receiving treatment to a group of people not receiving treatment, those people are inherently different from each other. So how can you determine what's the best group to compare them to? We also have other issues, such as the people that end up staying in your study and completing it are different than people that drop out. Because picture you're in a treatment study, it's 3 weeks in, and maybe the treatment's making you worse, or maybe it's just not making you better. You probably would drop out of it, right? Drop out of the study. Why keep putting your time and effort into it? And so just because the study shows that after 16 weeks, it helps the people that finish the study, it doesn't reflect all the patients because some of them probably dropped out. So this basically boils down to, there are many evidence-based treatments, meaning there are several forms of psychotherapy that science says work. But the problem is, maybe just because they work in science doesn't mean that they're necessarily going to work in real life. So I mostly thinking of CBT, or cognitive behavioral therapy. I could rattle off study after study that shows CBT is very effective, especially for treating depression and various forms of anxiety. But does that necessarily mean it works for every patient? No. So this, I want to kind of circle back to what I said. Just because some of the research suggests that antidepressants largely are effective because of placebo effect doesn't mean people should not take antidepressants. Just because research says psychodynamic may not be as effective as cognitive behavioral therapy doesn't mean clinicians should stop doing psychodynamic. It simply means there is more wishy-washy, murky, unclear stuff happening in the field of clinical psychology. It basically means things are not as clear-cut as most consumers would assume. This means that patients need to advocate for themselves. And I don't think people know that. I think people go into doctor's appointments just trusting their doctor. And I know why, right? They went to medical school, they went to graduate school, they're wearing the white lab coat, there's doctor before that person's name. Okay. We want to be able to trust the people helping us. But at the end of the day, we also need to educate people about how to ask the right questions and how to advocate for themselves. Because there is more wiggle room in the decisions than most people realize. Whether you leave your doctor's appointment with a prescription for an antidepressant, an appointment to see someone who's going to do psychodynamic therapy, or you're turned away with nothing, is often kind of just up to chance in terms of the provider's decisions or which provider you see. So this brings me to the end of chapter 16. And I like that we end on this chapter because I think the field of clinical psychology pretty nicely represents the field of psychology as a whole. We know a lot. We know a lot about people and why they do the things they do and how they think and how they feel. But there's still a lot to figure out. And I think that there's more uncertainty in the field than most people looking from the outside can see. And so again, this isn't to make you question things that impact you in your everyday life. Again, things like whether you take antidepressants or not, or should you see a therapist or not. This is simply to help you better understand where the field is and to better understand some of the limitations in science overall. The limitations and the controversies and the issues we talked about here related to psychology are present in all sciences. It isn't just psychology. So I hope everybody enjoyed the semester. Again, I am sorry that we couldn't be together in person. I couldn't see your smiling faces every day. But please reach out to me either now or in the future. And I certainly hope many of you consider majoring in psychology. And good luck with all your finals and all of your endeavors yet to come.